Okay, so kia ora koutou. Last webinar for the year, and this one is just recapping on some information regarding the association between smoking and sudden unexplained death in infancy, or SUDI. Okay, so what is SUDI? Well, many of you might know this as cot death, or sudden infant death syndrome, or SIDS as it used to be known. We've now moved on to SUDI, which is really about unexplained death, and it's really when an infant dies in a way that's unexpected and initially unexplained. So there's no other obvious cause for the baby's death. It most frequently occurs in early life, so the first 3 months, but certainly you can get cases in the first 12 months of life. And in New Zealand, somewhere around 60 to 70 babies die every year from SUDI. We have got better over time. Now these, if you look at just the left-hand side of this graph, that's showing you total SUDI deaths per 1,000 live births. Okay, so this is just the way in which it's measured or reported here. So in 1990, 1991, for every 1,000 births, there were around 2.5 deaths. Or for every 2,000 live births, there would have been 5, if that makes sense. Over the years, this has improved, but there's been a bit of a flattening out, of course, in the latter few years. If you look at the right-hand side of the graph, this shows the problem we have in inequity. So rates among Māori are much higher than the rates in Pākehā, or New Zealand European. So you can see there, here rates in Māori, and here rates in Pākehā.
Hayden, just on that graph, why is there an increase in 2011 in Pacifica and Māori populations? Is there...
In 2011, I mean, here, is that what you mean?
Yeah, so the rates are going up?
These are quite small numbers, remember, so you only need to have one extra, and it looks like it's gone up a lot. But important just to keep a look at the trend over time, which is, good news is it's a downward trend, but you've still got this inequity here between Pākehā and Māori, and even Pacific. Now, risk factors. There are 4 major risk factors for SUDI. Prone sleeping position, that means lying on your front. Maternal smoking, especially during pregnancy, in particular here. Lack of breastfeeding, and bed sharing. Okay, so they're the four things that we're trying to reverse. There's been a lot of good research in New Zealand, and Professor Ed Mitchell's really the one that's done a good chunk of this. And in some earlier work, Ed and his team showed that there was an interaction between bed sharing and smoking. So bed sharing and smoking are both independent risk factors for SUDI, but when you put these together, i.e. when infants of mothers who smoked during pregnancy and there was bed sharing, then the risk of SUDI was higher than having either one of those particular risk factors. Okay, so the sleeping position and bed sharing and smoking together are 2 key things. There are some other risk factors as well. I've already mentioned sleeping position, which this paper showed. There are also risks of baby sleeping on the side. So we need to encourage parents to put baby on their back. Postnatal depression also seems to be a risk factor, and fathers don't escape either. So smoking by dads is also a risk factor, independent of mum smoking in SUDI.
So with bed sharing, the problem is that baby is unprotected, yeah?
Yeah, that's right. And you can think about little babies in beds. The the effect of, you know, baby rolling into a bit of a hollow from heavier adults and, you know, landing the wrong way and not being able to.
You've just frozen there, Hayden. I'm not sure if you can hear me.
So that's that seems to be a protective factor.
Sorry, you froze there for a bit. We missed that last sentence or two.
Oh, sorry about that. So protective factors, use of pacifiers.
Which is what dummies, what
exactly, use of dummies. And sleeping in the same bedroom as the parents is a protective factor. So assumingly that means that parents can respond if anything goes wrong, sorry.
Oh, okay.
Now, rates in Māori, as I've already pointed out on that graph, they're higher compared with non-Māori, and the rates currently are around 1.46 SUDI deaths per 1,000 live births compared with non-Māori, non-Pacific of 0.45. So you can see that difference there. Now, this higher prevalence of risk in Māori is related to the higher prevalence of risk factors. So it's not because you're Māori that you have a greater risk of SUDI, but because of the risk factors such as smoking and bed sharing. That's really the problem. And these are things that we can help solve.
So in saying that, are you saying that Māori parents tend to sleep with baby more than Pākehā parents would?
Correct. Yeah, that's right. And it's not about not sleeping with your child, but it's about having them in a protective space. And we'll come on to that in a minute. But I just want to share with you here sort of the size of the problem, if you like. And what you're seeing here is odds. These are odds ratios. So it's the odds. So if you take the first one, smoking during pregnancy, the odds are 6 compared to not smoking during pregnancy. So that the odds of having SUDI in an infant are 6.
So 6 times higher than...
Yeah, that's right. If you sleep on the front, you know, prone sleeping position, it's almost 4. If you don't have your parents in the room, then it's almost 3. And if you share a bed with your parent, it's around 5. But again, if you smoke during pregnancy and bed share, then that odds ratio is almost 33.
Wow.
So it's this sort of double whammy effect here. And you know, this is where stop smoking services have a role, not only in helping mums stop smoking and dads stop smoking, but also to give information around bed sharing and making sure they've got something like a wahakura to put baby into if they are bed sharing. So it gives baby its own protective sleeping space.
So are you saying here that if whānau smoke or smoke during pregnancy or smoke after baby is born and they bed share, they're 32 times more likely that their baby would die of SUDI?
Yeah, that's right.
Okay.
So it's a significant risk, and sometimes we've done well with SUDI and we tend to forget about this, but it's something that we should keep in mind and discuss with whānau whenever we help young whānau, having especially those with infants or pregnant women. We should talk about the risks not only of smoking but also of bed sharing, and just that simple message. Now, I know we've talked about smoking and pregnancy before, but I just want to touch on this because it's still a significant issue for us. And around about 14% of pregnant women report that they smoke at the time of registration with a lead maternity carer, an LMC. But rates are quite high in young women under the age of 20. So 35% would report smoking at the time of registration, and 37% of Māori women report smoking at the time of registration. So although a significant proportion of women do give up prior to becoming pregnant, we've still got a significant proportion of young and Māori women. And you can see why the Ministry of Health's focused on supporting more young Māori women quit smoking. In terms of smoking 2 weeks after birth, is about 12% reporting smoking then. So you've still got some people that are remaining abstinent after they've given birth, but 7 to 8% of women who are smoking at registration, so they were smoking when they were booking in with an LMC, most of them are still smoking 2 weeks after giving birth. And that figure's almost 81% of Māori women. So we've still got a number of women that are smoking throughout pregnancy. And just to look at it in another way, these data are a little bit old now, but it still gives you that picture. This is by ethnicity. Darker blue bars are smoking before pregnancy, lighter blues are not. And you can see the difference there by ethnicity. And this is before pregnancy. If you look at during pregnancy, you can see 34% of Māori women, at least in this cohort, were smoking during pregnancy. So how does smoking in pregnancy increase the risk of SUDI? Well, it really predisposes the infant or the newborn to low oxygenation, or we call this hypoxia. So low levels of oxygen in the blood, which you all know our brains need oxygen to function, and without it, there's, of course, a risk of dying. Now, smoking predisposes infants in 2 ways. One, it adversely affects their lung function, especially their lung development. So their lungs, babies born to mums who smoke, their lung function is not as good as babies born to mums that didn't smoke. And the other key factor here is that smoking during pregnancy can cause sleep-related respiratory problems, especially episodes where babies just don't breathe. If they roll onto their front, they can't breathe, that's apnea, then they're at risk. And to put it very simply, babies born, mums who smoke throughout pregnancy, their babies kind of lack this fight or flight response. It doesn't really kick in as fast as it should do. So if baby, let's say, is in bed, rolls onto their front, next to dad, rolls onto their front, they can't breathe, but usually you'd have a mechanism where you'd get some gasp, suddenly you'd kick in, your heart rate would shoot up, you've got adrenaline pumping, and it sort of kicks the respiratory system into action. It appears that babies born to mums who smoke during pregnancy don't have this as much, or it doesn't kick in as fast. And this is where nicotine might be implicated here. So this might be a nicotine causing this or being associated with this. At least an animal model suggests that it might have a role in dampening down this flight or fight response.
And that's a result of mum smoking during pregnancy?
It's a result of mum smoking during pregnancy, yeah. So what should we do? What's our advice? Well, Hapai have some very nice acronym for this, PEPE, which really is about placing baby in their own bed in the same room as their parental caregiver. That's certainly best. Eliminating smoking during pregnancy and also when they're born. And this is about helping young whānau as well to be completely smoke-free in their house and their car. Positioning baby on their back with face clear of any bedding, and encouraging and supporting breastfeeding as much as we can. So
these are the simple messages that stop smoking practitioners could give to families.
Yeah, absolutely. But you can go even further. If they don't have somewhere for baby to sleep, help them find somewhere. There are lots of resources in DHBs. So I know some of the services check this systematically, where they'll go through and say, actually, do you have a safe sleep device, or do you know how to the safe sleeping position.
Which is on your back.
Yeah, which is on the back. Have you thought about breastfeeding? Do you need some support in helping you to breastfeed? So there are some ways in which Stop Smoking services can do this.
And it's not that hard, really, is it? It's quite...
It's not that hard, but it's about putting it into your corridor as you go through. Now, we have some good ways to help people quit smoking. You know, you've got all the brief advice stuff, but you know, it's about helping our LMCs have positive and non-judgmental conversations. They shouldn't be pointing the finger or telling people off. A lot of these women are stressed. They've got a lot of things going on, and smoking can sometimes be their sort of support or coping mechanism. So it's not about giving in and saying, oh yes, I understand, keep on smoking, but really having some empathy in the conversation, but focusing on what you can do. And I think the best thing hapu mama and their whānau can do is enroll in a Stop Smoking service, because this is still going to provide their best chance of quitting. We know financial incentive work, we know nicotine replacement therapy can help, and we know face-to-face support also increases the chances of quitting, not just throughout the pregnancy, but longer term as well. But what more can we do? Well, I think we've got to start moving a little bit differently here, and especially acknowledge that you know, SUDI is an issue which disproportionately impacts Māori. So we can't ignore this. We've still, although we've got had a decrease in SUDI rates over time, there's still that gap between Māori and Pākehā. And I pinched these slides from Faye Selby Law at Hāpai, and you know, I think these are sort of these good concepts that we should be taking into account more as we redesign our Stop Smoking services. So it's not about throwing out all the things we know with what helps, but it's about moving in a way which fits better with Te Ao Māori. And using a wahakura, and you can see a picture of the wahakura there, are culturally affirming, they're sustainable, they're made out of harakeke, locally produced in many situations. You know, some services are teaching hapu mama to weave these themselves. And I think in doing this, the other information that we need to or like to convey can be sort of woven into those conversations as they're making wahakura. You know, that's just one potential option there. So it's about really taking a slightly different approach to all of this, and using a whānau-centric way, using what we know from Te Ao Māori to really enhance what we do in Stop Smoking services. And look, this might mean you know, decentralizing health services a little bit, moving it from all DHB and relocating within communities, within iwi. And I know lots of the Stop Smoking services are now moving to connect better with whānau, hapu, iwi. They are thinking in different ways. The Ministry of Health have really moved things along in this way, in focusing on wahine Māori, especially young wahine. So there's a real effort to move in this way. Have we got the perfect answer yet? I don't think so. Some of you may be able to give me a bit more information, but it's about moving away from just delivery in a clinical style and becoming more flexible, adaptable, making sure you fit the needs. But it's not about throwing out all the knowledge that you have as well. The trick, I think, or the skill is integrating it into a system that sort of better suits, or that it's the interface between the science that we know, or the clinical support, and making it appropriate for Māori. Some of you might have some views on that. They're just mine. I think, you know, really trying to increase awareness, knowledge, understanding about wahakura from the Māori worldview, looking at how we can amplify voices of Māori who are working in this field, and that includes people in Stop Smoking services. Given smoking is a major risk factor for SUDI, we have a really important role to play here. And sharing the insights from Mātauranga Māori, I think we'll make a difference not only for our Māori whānau, but for Pākehā as well. I think especially those from lower socioeconomic groups that are struggling with many aspects of life as well.
So, just on that,
yeah,
how would you approach a whānau who's saying to you, well, my mum smoked, all her babies were fine. My nan smoked, all her babies were fine. So I don't see what the problem is here.
Yeah, and look, I think it's the same way you approach anyone that says, oh, well, my dad smoked and look, he's 99. The fact is that we know that smoking is a risk factor for SUDI. And yes, there are many children born to mums who smoke that don't die of sudden unexpected death in infancy. But the fact is that it's a major risk factor. And when you're combining smoking and bed sharing, that's a 32 times increase odds of SUDI, which is pretty significant. And I don't think it's about lecturing people, but it's about supporting them to know that actually this is a risk factor. But the good news is we can help make a difference with giving information about position for sleeping, eliminating smoking, encouraging breastfeeding, and preventing bed sharing.
Okay, but just going back to your comment about nicotine maybe implicated in that lessening of the fight or flight response in newborn babies. In that case, why are we using patches and gum?
Well, nicotine's one risk factor, and yes, nicotine may be implicated in SUDI, but there are other risk factors, of course, for smoking and pregnancy which don't relate to nicotine. So it's not all about the nicotine, but this is also why we all give information about when we're using nicotine patches and gum that it's not 100% safe. There are some risks potentially associated with nicotine, but they're less than smoking.
Wow.
So just to conclude this nice short and to the point webinar, we are making a difference in SUDI. Rates have decreased over time, but they still remain high, especially among Māori. And remember, it's not ethnicity that's causing any of this, it's the risk factors, especially smoking and bed sharing. Supporting hapu mama, pregnant women, to quit smoking remains a priority. It should continue to be a focus for us, but we do need to continue to innovate with specific focus on better solutions for Māori. I think that is that. Happy to take any questions.
Okay, I've just got one question for you. Sorry to take over here, but then we'll open it up to the floor. So using patches and gum to help pregnant women come off smoking, obviously that's much better than they're continuing to smoke through their pregnancy. I know I've heard you in the past say that pregnant women who continue to smoke are often the most highly tobacco dependent smokers. So they would require maybe more nicotine to help them stop smoking. How much is too much?
Well, we don't know how much is exactly too much unless you're taking measures of their nicotine consumption prior to quitting smoking, which you can do, but it's not very practical within our setting. So the rule of thumb is to use the minimally effective dose. So you start low, you increase over time to try to get to the point where they're no longer smoking and not having any withdrawal symptoms.
Okay, so you could double patch in 4
Yeah,
minutes.
you could double patch. Remember to take the patch off overnight, of course. But you just have to take it, but step by step. You're not going to be able to go in with a pregnant woman and say, aha, I know that you're going to need 3 full strength patches on this at the time.
Thank you. Okay, so I'll unmute everyone now, so you will be able to ask any questions you may have. So here we go. Oops. Are there any questions? Doesn't look like it. So Hayden's obviously done an amazing job. So if there's no questions, I'll say thank you very much, Hayden. And
Okay.
Merry Christmas to you and everybody else.
And I hope everyone has a lovely and safe Christmas and Happy New Year. And I guess, Grant, will be starting these up in late January or early February again.
I think so. We've just while I've got you here, we've had an interesting request for a topic around supporting older people to stop smoking. And I thought that was a very good request. So if you do have some topics you'd like to cover in 2020, just email me with your topics and we'll schedule them in. So on that note, thank you for taking part. Do have a Merry Christmas and we'll see you in the new year.